clinical psychopharmacology and complementary medicine. He has been a mentor to hundreds of trainees through the new investigator program that he started for the American Society of Clinical Psychopharmacology. He also co-founded APA's journal, Focus, with Deborah Hills, and served as its editor-in-chief until recently. Dr. Rappaport is a distinguished life fellow of the APA, and prior to his current academic position, he was a Leonette Harris Chair of the Department of Psychiatry and Behavioral Sciences at Emory University, the Chief Psychiatric Officer for Emory Healthcare, and a founding co-director of the Emory Brain Health Center. So now if you would help me in welcoming our moderator, Dr. Mark Rappaport.
Fatima, thank you very much for that introduction. The other thing that it suggests is that I'm old, and I am, but I'm really thrilled to be with you tonight. And I'm thrilled that the APA and Fatima and others have put together Looking Beyond. Because this is a chance for us all to stretch. This is a chance for us to go beyond what we do every day and really meet with and learn from individuals that are doing exciting and innovative work in our field. And also learn from them some skills and techniques and approaches that can help us be better clinicians, better teachers, better scientists. Today we're going to be talking about different aspects of the relationship between the body and the brain. That's what metabolic psychiatry is all about. It's interesting. Some of the first work in this field began many, many years ago. My dear friend who just passed away, Bruce Lydiard, and Emery Meyer, back in the 80s, began to look at the interaction between the brain and the immune system. Gosh, back when I was interviewing for residency programs, Paul McHugh talked with me about the discovery of CCKA and CCKB. CCKA standing for elementary, and B standing for the brain. But the key is that with our advances in technology, with our advances in medication, approaches beyond medication, as you'll hear about today, what we've really begun to be able to do is look at the linkages between changes in the body and changes in the brain, and the bidirectional interaction of those changes. And why is that important? It's important because our patients die with serious mental illness 5 years earlier than those without. That's an equity issue. It's important because many of our patients live in a food desert. Because of that, their nutrition is such that it contributes not only to obesity, but potentially, as you're going to hear tonight, to their psychiatric symptoms as well. So tonight, what we're going to do is hear from two, to me, young, I guess they would call themselves mid-career experts, who really are changing the field, changing how we think about psychiatry and metabolism. So our guests tonight include Dr. Shivani Sethi. She's a clinical associate professor at Stanford University. And she is a physician scientist who specializes not just in psychiatry, but also is boarded in obesity. And she and her colleagues have really done tremendous work in this area, investigating metabolism and psychiatry. In fact, she's referred to coined that phrase, metabolic psychiatry. She's also an innovator, not just in terms of the classical ways, but she's founded a company that does work in this area as well. And I think one of the things important in our field is to understand that there are many ways of getting our messages across, and many ways to contributing to the care of our patients, not just in terms of our work as clinicians or educators or researchers, but also as business individuals, so that we can really encompass all approaches that help our patients and families. And so she is the founder of the Metabolic Psychiatry Labs. And I'm really excited that we're going to be able to be working with her tonight. Our other, as I said, very young but good career speaker tonight is Maher Agarwal. Well, I've had the good fortune of having him here for a number of years. Now, he's had to put up with me at both ACMP as well as the ASCP meeting. Maher is a psychiatrist and medical head of clinical research in the schizophrenia branch at CAMP. He's a scientist in the Campbell Family Mental Health Research Institute and an associate professor in the Department of Psychiatry there, and the Canada Research Chair in Metabolic and Cognitive Health and Mental Illness. So as you can see, these two individuals are quite busy and quite accomplished. So what we're going to do is I'm going to moderate a series of questions that will sort of begin the discussion, but my hope is that the three of us all will interact together, and then in the last 10 to 15 minutes of our time, you'll have a chance to pick the brains of these brilliant folks. So, Shivani, let me start with you. Why don't you talk a little bit about coining this term, metabolic psychiatry? Why'd you do it, and what does it mean to you?
Thank you, Mark, for that very beautiful introduction. I don't think you're old. I think you're wise. And I would say that although you might think we're young, I think I have good metabolic health. I'll say that. So just to, I guess, zoom out on what metabolic psychiatry is, and you mentioned that this work really has started some time ago, and it's something that we gave a name to, but researchers and scientists have been looking at what the relationship of metabolism and mental health has been almost 100 years ago. So we had markers of elevated lactate levels and lowered glutathione as markers of bioenergetic dysfunction in bipolar illness and schizophrenia. For decades in our field of psychiatry, we treated metabolic dysfunction like weight gain and insulin resistance as really like a side effect to monitor, but not necessarily a target in treatment. And that's really changing actually quite rapidly in just the last 5 years. And I can speak to that more later. However, when thinking about metabolic psychiatry, it's really looking at this relationship and study between metabolism and mental health, and what metabolic treatment targets and pathways are we looking at both centrally and systemically that can potentially improve psychiatric outcomes. And so that's really what it's about. Insulin signaling in the brain, chronic low-grade inflammation, mitochondrial function are really upstream and not downstream consequences of medications that we use. You mentioned the equity, lack of equity of losing 10 to 25 years of life expectancy, largely due to cardiometabolic disease, and I think a lot of our field is aware of that. However, thinking about treatment targets and how to improve metabolic health and mental health simultaneously is kind of a different frame. And this is just something that I noticed very early on in my career during medical school, kind of at the bedside, that folks that had treatment resistance, they tended to have these markers, metabolic dysfunction markers, or higher inflammatory levels. And so that's kind of how I got very interested in this topic and this area, both clinically and with research. So that's how I guess went into it. and saw patients that were improving. And we have now been working with a lot of folks around the world, really globally, and put together a statement on what the framework of metabolic psychiatry is just a couple months back in the Nature Mental Health review with 17 scientists, and it was a collaboration that I initiated with these folks as well as in 5 countries. So I'm proud of that because that is a way to kind of move the field forward, and that was my intention.
Well, that's great. Now, Shivani gave you a real in here talking about this. Do you want to talk about your work?
Yeah, thank you, Shivani, for that perfect setup. And Mark, thank you for the mentorship that you provide across functions. I would be lost at the ASCC and ACSC without you. So thank you for tolerating me. This work is really interesting, and I couldn't have said it better. Shivani has framed it very nicely that we started out thinking of this as side effect management. And it's not that that aspect of our work is done. There are real battles to be fought there as well, and we continue to fight them, and we'll discuss that in more detail further along, I suppose. But this interesting concept that this could actually be related to psychopathology is very much a testable hypothesis and provides for rich questions, rich sort of subset of questions that can be framed from a metabolic health point of view. So insulin in the brain is one such example. We know that insulin in the periphery is critical in managing glucose control. Over time, physiologists and endocrinologists have realized outside of the role of insulin in the periphery, insulin plays an important role in the brain as well. And when we look at the brain, about 40 to 50% of glycemic control is probably centrally mediated, but above and beyond, it may have impact on eating behavior, feeding preferences, potentially cognition, and then potentially psychopathology as well. And so those links have encouraged this conceptualization of insulin action in the brain to lie at the crossroads of cognitive and metabolic illnesses. And one could argue that several of the illnesses that we treat in our day-to-day practice lie at that intersection. And so my research has focused on looking at how it applies to antipsychotic use and in depression. So we have initial findings, some of it published, some under review and various stages of preparation. But essentially our findings are that in youth who develop depression, even before they show any sign of peripheral metabolic ill health, there are evidence of brain insulin resistance in these individuals. So this is a pilot probe that was recently issued in Psychopharmacology. Interestingly, we found that the degree of insulin action abnormalities in the brain correlates with clinical outcomes at the end of 6 months. Admittedly, this is a small sample, it's not a study, but it does show that even before peripheral markers of metabolic health are present or evident, you can see markers of that in the brain. And that goes back to the point that Shivani was making, which is that potentially metabolic abnormalities lie upstream of disease processes, and therefore they can be targeted at that level. Treatments add to that, and that's a separate and additive issue, but there is a window of intervention or understanding the pathophysiology of the common and severe mental illnesses, or at least a subsection of these illnesses which can be targeted using metabolic intervention.
You know, the interesting point that both of you made, that I think is worth just highlighting, is that there is not this dualism between the brain and the rest of the body. And that these pathways are present in the brain and the rest of the body. That there's this bidirectional action going on all the time. You know, and that reminds me by some of the really exciting work that you've been doing, looking at ketogenic diet. Don't people understand the work you've done?
Sure, yeah, I'm happy to talk about that. I have a comment from what Mahavir said. It's really interesting. I think the point of central brain insulin resistance versus peripheral is the distinction that you made, because you can test for insulin resistance peripherally, but that doesn't necessarily mean that person may not have insulin resistance centrally. And you mentioned detecting peripherally metabolic health, abnormalities that maybe came later after the depression diagnosis. And I'm going to mention, I like to give credit to other colleagues at Stanford that this work, they looked at insulin resistance peripherally, which is 1 in 3 statistically in our country, and having that gives you a double risk for developing depression later on. So this bidirectional, comment, Mark, that you made is really spot on, because here is just an example of that, of this bidirectional relationship. And even with bipolar illness, you have a higher BMI initially, then you have a higher risk of developing bipolar illness. And so these relationships really do exist. So there is data also with before first episode psychosis that there's a detection of insulin resistance as well before any drug exposure. So this is separate from medications, and so that's another argument as to why there is this bidirectional relationship and not just the side effect of medication. So about the ketogenic diet, and I like to call it ketogenic metabolic therapy, it's really been a therapy that's been used in the treatment of both pediatric and adult epilepsy. And there's been a lot of meta-analyses and literature on how the mechanisms are present with ketone bodies and what that does in the brain specifically. Why does it reduce seizures? So I did come from the obesity medicine world where it was being used, and I was trained in the South looking at this for folks that had metabolic syndrome, obesity, and insulin resistance. And what I had seen at that time is that the patient with treatment-resistant schizophrenia delusions and hallucinations were improving while on this ketogenic therapy. And that really got my interest in understanding how it affects psychiatric outcomes. So I adapted those protocols and learned from our colleagues in neurology how they approach ketogenic therapies. And that's why I started studying it in the SMI population. But largely, ketogenic therapies, there are several kinds. There's generally 4 classes, and there's one more classical versus a more lighter version. And we think about ketogenic therapy as it's a high-fat diet. It is a low-carbohydrate approach, and it's a moderate protein eating pattern. And there are several mechanisms, and I don't need to, go through all of them, but one thing that I should mention that I think is important, especially when thinking about brain energy metabolism, is that you're bypassing certain metabolic pathways with ketone bodies. When you're on a ketogenic diet, you're burning fat, and your blood will have BHB, beta hydroxybutyrate, which is generally the ketone body that we measure to see if they're following the diet, if they're adherent to the diet. It crosses the blood-brain barrier. It actually goes into cells without insulin is not really needed through different glute receptors, and it will bypass some of the pathways of building and creating ATP through the Krebs cycle. So it'll go straight in a different pathway. So you end up in the same place, but you're going through a different route. And the reason I mention this is because the brain energetics and metabolism is something that has been shown to be altered, whether it's insulin signaling or glucose signaling in the brain. And the concept of cerebral glucose hypometabolism is present in many neuropsychiatric diseases. So you essentially have these cells that are not able to use the glucose around them. And so that's why the ketone bodies are helpful in creating ATP. And the cell is no longer starving. So that's one mechanism of generating ATP. The second one that I'll mention is it's considered an anti-inflammatory diet. It works on certain pathways to inhibit, for example, the NLRP3 inflammasome. So when we think about astrocytes and microglia, either the structural support, or your immune system security guards, which are very important for your neurons, thinking about inhibiting that inflammatory pathway is one area that has been consistently been shown and with signals across all trials.
That's interesting, because speaking of that, one of the things that inflammation does that people forget about is that it shifts metabolism towards the immune system and away from other systems. So, as you were saying, it causes even a greater sort of deficit of potential energy sources. So that's very interesting. Javier, you've done a lot of work recently also looking at GLP-1 agonists and other types of approaches to helping folks with serious mental illness. Do you want to talk about that a little bit?
Oh, absolutely. And I also wanted to add on a comment to what Shivani brought up about the bipolar illness and metabolic health therein. So to close the loop, everything she said is spot on. And Cindy Calvin from Halifax was one of our collaborators, found that this could actually be therapeutic. So yes, there is bidirectional relationship. So metabolic health leads towards bipolar outcomes. First episode, more treatment-resistant illness. But then she performed a clinical trial where she randomized people with treatment-resistant bipolar depression who had insulin resistance to either metformin or placebo. And she found that people who were in the metformin arm and reverted in terms of their insulin resistance had lower depression scores and better functioning at the end of the trial. Now imagine, this is metabolic psychiatry in action. This is showing metformin as primary antidepressant in treatment-resistant bipolar disorder. Admittedly, not everybody on metformin approved. And then we are trying to find out. So now we have federal funding to repeat this, multi-site study here in Canada. Maggie Han is the VCI, and we are going to do this study in Toronto, Ottawa, and Calgary to replicate these findings and to investigate whether metformin can really do that in larger samples as well. But this goes to show that metabolic intervention can have measurable, real impact on mental health. Now, the question that you asked, which is about the work that we have been doing in the metabolic clinic around metabolic health management. So that comes from a different lens, which is sort of the core of how the work initially got started with the advent of the so-called second generation antipsychotics. And so this clinic was set up in 2004, when the recognition, early 2000s, when the recognition of metabolic health impairments with some of our agents was growing. And so over time, we have developed an algorithm which is largely pharmacologically based. People who work in this clinic are psychiatrists, and we are mostly psychopharmacologists. And so while we appreciate and understand and advise lifestyle approaches as required and as recommended, and we also have a keto pilot happening in our clinic, again, generously funded by the Business Group. We focus on how psychiatrists and other practitioners around them can use drugs like metformin and glutamate and semaglutide to improve metabolic health outcomes, to reduce the side effects of psychotropics that we use in our primary practice, and push it to it and how it could be done. So we have generated guidelines and protocols and flowcharts to that effect. And the sum of that is that we believe that perhaps, again, every system can solve this depending on how the system exists and works. But we feel that primary metabolic health management could perhaps be managed by the psychiatrist. And we have in the University of Toronto encouraged our residents and learners to think of metabolic health and the metabolic health side effects on par with extrapyramidal symptoms. So if you as a psychiatrist can prescribe an antipsychotic and feel competent to prescribe benztropine to manage extrapyramidal symptoms, you should reasonably be comfortable in prescribing metformin, which is a first-line management for metabolic health, in a preventative to early interventional framework. So, if you're starting a languagine or clozapine, or if your patient has existing metabolic health problems, think about starting it early if you see signs of early weight gain happening. And so what we're trying to do is to empower psychiatrists to be able to do that themselves while still providing the support in case either training or comfort prevents them from doing that. And so we have built a stepwise approach where metformin comes first, topiramate is a close second, and semaglutide, because of its cost and lack of a lot of data, comes next in terms of mental health management. And we have shown in a recent paper that this hybrid approach could lead to a situation where the number needed to treat is in the range of 3. If the outcome is 5% weight loss. If you think that the outcome is 7% weight loss, the number needed to treat is about 4. And so what we are showing is that a psychiatrist-led approach to metabolic health management is feasible, safe, and effective.
And so what you're doing is creating sort of guidelines or algorithms, including the types of outcomes that should be monitored by the psychiatrist. Is that correct?
Absolutely. And we are trying to, again, we appreciate that this is somewhat of a change in our practice. And so we are trying to keep it as simple and straightforward as possible. And so the advice generally is, think about co-prescribing. Think about preventing it, because prevention is better than treatment. If you or the patient, for various reasons, is not in the headspace, then please think of it on an ongoing basis and try to do it sooner rather than later, because again, early intervention works better than late intervention. And so we are trying to put this thought front and center when you're talking about clinical care in a primary mental health setting.
So Shivani, you've been doing that too. You've been developing a variety of educational protocols and approaches for a host of different aspects of the work that you've been doing. I have 2 questions related to that. One is, how do you select the patients that you're going to want to put on to ketogenic treatment? And then also, once you do that, how do you educate both the patient and the clinician about what to do?
Yeah, so there's a lot to say about that. So Mahavir, thanks for talking about the Trio BD trial. Actually, huge fan of Cynthia myself. And one of the conversations we had also was she thinks that the metformin and blood-brain barrier leakage is like a marker almost, which I thought was really interesting. And you were talking about how much it improved. That I believe it was like 50% of individuals that had that improvement in insulin resistance, and then the ones that, when looking at the improvement, it tracked the depression and anxiety. So I'm really excited to hear that you guys are expanding this and looking at more data. And then to answer your question, Mark, I'm going to go back to that. I think all of this is very important and related because, when I did the pilot study of the ketogenic therapy it was in schizophrenia and bipolar, we looked at, insulin resistance markers, we looked at advanced lipid markers, we looked at clinical outcome data, and just to highlight, like 32% had a reduction in BPRS, 31% had an improvement in the CGI severity. Every person that had metabolic syndrome at steady start no longer had metabolic syndrome after 4 months, which was a really nice finding. With very preliminary, data, obviously a smaller, admittedly, but we saw markers that were improving in all directions, which was really encouraging. And even with the insulin resistance, with the HOMA-IR, adherence was good. Inflammatory markers went down. So the population selection there, because you asked me about who's going to benefit from it, who's not. Those are great questions. I don't think that the pilot could answer that question. We need larger data sets to be able to answer those questions. The good thing is that now there's globally 9 or more randomized controlled trials in ketogenic metabolic therapy in various diagnostic categories with I was a co-investigator in a trial at UCSF that was published recently, where we looked at ketogenic metabolic therapy with schizophrenia and bipolar as well. And there's also a lot of changes that you could see that we're tracking in various of these categories that I mentioned. But also, very interestingly, it wasn't just weight loss correlated with the symptom improvement. It was really the ketone level, the ketosis, that it was tracking to. And I think that's an important kind of finding from the study. When we look at the studies from the field of neurology with seizure improvement and who responds and who doesn't, they're 1/3 generally don't respond. And then 1/3 do respond some, and then the other third, they respond very well. So who responds and who doesn't is still a question that this field, hopefully will answer over time with more data that's collected. Now we are starting a randomized controlled trial now at Stanford, which is transdiagnostic, looking at ketogenic metabolic therapy in schizophrenia, bipolar, and major depressive disorder. And we are looking at microbiome changes, we're looking at genetics, we're looking at deep omic profiling to really gather as much mechanistic data as we can, including mitochondrial genetics, which, by the way, we're collaborating with Anna Andresa from UC Toronto on that. Also Mayo Clinic for other markers like GF15, as well as looking at downstream markers of ketones, so ketone metabolites, with a faculty member at Stanford as well that specializes in that area. Mike Snyder also is a co-PI on the trial. He was the chair of genetics for many years at Stanford. So I think the deep omic profiling is going to be the newer component that's added into the study. And so to get towards the trial and error and more towards precision psychiatry is really, or precision metabolic psychiatry is really our goal. And so the more data that we can collect, the better. Obviously, this is a non-pharmacological approach with, pharmacological trials. We did look at the obesity drug in the past. We did an RCT looking at eating disorder population. I wish mechanistically we looked at all those things before, because I think that would have been really interesting. From one of the pilot studies out of the UK by one of our colleagues, Ian Campbell, he looked at ketogenic metabolic therapy in bipolar specifically and saw that the ones that tested positive for insulin resistance at study start tended to have more improvement. So it's very, small amount of data, obviously, that we can make conclusions like that, but it's a signal and something for us to, look at further with more, hopefully with more research.
Aaron, what are your thoughts about what Shivani was just saying? You had this look on your face, like, oh yeah, I get this. So
yeah, no, absolutely. So I come from a poverty mindset. I feel our field could use a lot more discovery, a lot more excitement, and I'm ready to beg for a field from whichever field is ready to give us therapeutics to make our patients better, right? And so if that's what we are hoping for, something new, because our drugs are synaptic approaches for a while, and while they have been helpful, they have not solved all our problems, and so we are in the market for new things, and this is the way to find it. You look at a signal in another field, you try it out in your field, see if it works, predict who will benefit, who wouldn't, and this is how research progresses. So yes, I'm very excited about all the work that is happening, and I wait to find out what ketone approach can do for us, the ketogenic diet, the ketogenic metabolic therapies can do for us, and also all the other medications that are coming at us. I mean, this is a very exciting time to be in this field. The advent of GLP-1s and their various next generation therapies. Also, for the first time, the non-dopaminergic antipsychotic. And if somebody had told me in terms we would have all of these new ways to think about and potentially address these problems, I've been updating them, and I'm very excited that all of this is happening at the same time. So yeah, that was the look.
Oh, good. Yeah, it's a great explanation. I'm excited that, there's so many, people interested in this and building metabolic psychiatry clinics. Also, I think I saw one thing that's starting in the UK, and it's really expanding. And so I think the more data that we can, collect and collaborate on to understand, this treatment response versus non-response will be really valuable. As far as Mark, the question you asked me earlier, which I realized didn't answer yet, on the things I'm doing in terms of algorithm, I spend a lot of my time actually building that out, and there are a lot of different metabolic tools. Ketogenic metabolic therapy is one very powerful tool that's continually being studied, but there's a lot of other medications, whether they're anti-inflammatories or whether they're sensitizers that work on pathways that overlap, which I described in the paper. But looking at that as clinically, what would make sense when is what I've spent a lot of time on in training other clinicians, and I have found that, especially with the spin out from Stanford for Metabolic Psychiatry Labs, which is really about patient care, is one thing I realized is that being able to train takes time, and building out tools even with AI tools are very helpful for that. And so I'm hopeful and very excited for our future that we can, as soon as we are able to get the evidence base, really understand and translate the evidence-based science into translating in care. That'll be nice. I had thought about doing a fellowship training at Stanford, which I had discussed with my chair some time ago, but then at the same time thought it's going to take a long time. It's a long process to do that, and that's also probably why I decided to start the company too, because there's two things I care about. Is one is access to care, and then two is the science, evidence-based science, because I want patients to really have evidence-based approaches and not snake oil. So part of the reason, I was in DC that week, I was Society at the Forum, is I was meeting with Medicare. They have an access, and we're also on equity, is that the access model for care is really about depression and anxiety. It's not SMI, and so I'm trying to convince them to include SMI. So I'm working on a proposal right now for that. And yeah, that's I think an important thing for our field, because it's really, you can only work within the system you have to be able to provide the care. If that system doesn't support that kind of care, then it becomes a lot better. So
it does, but it sounds kind of like you're doing both tremendous science and tremendous advocacy. One of the things that I really like that both of you talked a lot about is being clinicians and scientists, and being clinicians and teachers and educators. And that so often, unfortunately, some of our researchers and educators forget about being clinicians. So I'm so glad to hear that both of you talk passionately about care for patients and how important that is. So Mahavir, if you were going to advise somebody who's out in practice busy about initiating, whether it's metformin or a GLP-1, what would they do and what would they monitor?
Thanks, Mark. Your point about being a clinician and treating our patients as we do our research is well received. I've learned from you, and all my mentors have been clinician scientists themselves, and so it's a forward-feeding cycle, and I hope that I inspire some of my junior colleagues to take this up as well. With regard to metabolic health management, if somebody has not been doing it or this feels new to them, it can feel overwhelming to try medications that feel foreign or something that you're not used to. And I think metformin is a very easy task to get involved with and get started with. And so a lot of the times when we start teaching residents about it, start with the example of metformin, and a way of, again, using the benzocaine and EPS example is that metformin is clearly safer than benzocaine. It is safer than clozapine and lithium, which we all are able to prescribe. And so the idea is to look at metabolic health as a clear health indicator. And so if you are going to treat it, measure it. Some of our mental health settings may not, for example, be set out to measure basic things such as weight and waist circumference and blood pressure. So have the setup available to measure it often. If you find abnormality in your regular screening blood work or weight-related parameters, then do something about it. Either train or refer on. And training is as simple as starting metformin. Metformin is the most commonly prescribed anti-diabetic agent. It is safe, effective. It can be started at 500 milligrams once a week, and every week it can be increased by 500 milligrams to reach a dose of 750 to 1000 milligram BID. In terms of blood work, we do fasting glucose, fasting lipids, fasting insulin. If you can't get fasting blood work, that's fine. Do get an HbA1c and lipid panel, and do a vitamin B12 level and renal function test to ensure that it is safe. And then these parameters, the renal parameters and B12 can be repeated yearly to ensure that metformin can still continue, can be safely prescribed. If B12 levels fall, sometimes they can fall, they can be supplemented, and the fasting blood work can be repeated every 3 months until it normalizes, and then yearly thereafter. And so this is very much within what APA came out in 2004, except they, I think, stopped at monitoring because that was okay at that time. I think we should go beyond monitoring. We monitor, but also intervene. And so metformin is a very easy drug to start with. GLP-1s are also interesting, and they are quite effective. And in fact, with the advent of GLP-1s, the excitement has actually led to higher prescription rates for metformin. This is so interesting. It tells you that now people are getting interested. This is a treatable problem. This feels tangible and solvable. GLP-1s can be initiated with the help of a general practitioner and endocrinologist, but we have also been training psychiatrists to do that, and they are, again, as the data suggests, reasonably safe drugs. They do cause GI side effects, nausea, vomiting, and can cause constipation. There are risks of pancreatitis and cholelithiasis. But within those risks, they can lead to significant weight loss and can be beneficial to our patients. So that is one thing I would like to highlight from an equity point of view. Some of our medications can interact with GLP-1, but I don't think the potential interactions should prevent us from exploring that as therapies were indicated. Our patients often are the last to receive any advance in science, and I think that should not happen with GLP-1 because they are so very needed in our field of work.
Shivani, add to it, because I saw your face.
Oh, sure. I have some thoughts around the GLP-1. So, I think there's a lot of promise in looking at GLP-1s, outside of improving, weight and glucose and metabolic markers that we traditionally, measure, and just looking at psychiatric symptoms, whether it's food cravings, binge eating, whether it's substance use, whether it's early cognitive function signal and the depression, so early trials. Obviously need replication, but whether it's GLP-1s or metformin, one of the things that I often see, especially in these obesity medicine companies and telehealth, and I've advised in the past also, that it's very important to also look at visceral fat and muscle mass. And, I do not prescribe GLP-1s if the patient does not agree to do some resistance training movement, because I'm thinking about the long-term, effects for them. And, even we use GLP-1s, off-label for eating disorders, way before the attention on GLP-1s and new drugs have been out in the market. And this is a very important part, especially in obesity medicine, that I'm looking at nutrition components as well, because it can affect certain vitamins, it can affect certain, absorption patterns, and we have to take that into account. And so those are things that I really emphasize when I train other clinicians, when I see patients, that I think is important. So I think to the idea of psychiatrists obviously doing baseline metabolic labs like fasting glucose, A1C, at least a basic lipid panel, maybe a waist circumference, and to be in mind that doesn't cost a lot, to the standard psychiatric intake. That should be, in my opinion, even before antipsychotic initiation, or their medication is low cost, it's immediate action that's available, and it can be monitored. But I think other people have different levels of comfort of what they feel comfortable prescribing and how much knowledge you have around something. And so I think to respect that, if there is a endocrinologist they can work with, or a primary care physician they can collaborate with, or a nutritionist that's well versed in these, then that's great. If they want to refer out to this growing, metabolic psychiatry area of folks that are trained in kind of this dual, that's also another option. We provide support actually to a lot of other clinicians who may not be interested or want to do those pieces, but we help with the metabolic piece for them and give guidance, or if they want training. And we're hiring, more clinicians and expanding, so if anyone wants to collaborate and work with us, they're welcome to. I'm happy to point to other folks that also know who try and build these clinics at academic centers and so forth. So those are my thoughts. I'm very careful, I guess, and conservative in that perspective when I prescribe, and making sure that those things are measured early. And I like the idea of prevention and thinking kind of long term, because one of the things, at least, that we really emphasize in the obesity medicine space is if you are on a GLP-1 and you're losing weight, but then you get off of it and there's a weight regain, you're gaining fat mass, you're not gaining muscle mass generally, right? And so then your body composition changes, and we worry about sarcopenia. So those are things that I would just caution.
One of the things that we haven't talked at all about is very interesting. I just realized this a few minutes ago. We haven't even talked about statins. We haven't touched statins at all. And, again, if you think about metabolic psychiatry, you got to think about the role of statins as well. Do either of you want to comment on that for a minute?
It's a big topic, but yeah, one of your feel free.
And Shivani can add caution and guardrails around it. So So there is a fantastic guideline/review paper coming out in Psychiatric Bulletin. I don't know if it's out already. This is again work out of our Ireland, our wonderful colleagues who made these flowcharts and guidelines, which encourage psychiatrists to again intervene or refer as their comfort allows. So think about again in the narrow field of antipsychotic-related metabolic dysfunction, it tends to be at least at the start more glucose-driven. So you see dysglycemia and you see hypertriglyceridemia. Which tends to, again, respond to metformin, unless we are talking about, hypertriglyceridemia that can put you at the risk of pancreatitis, which can respond to anti-glycemic, anti-diabetic agents. So it can be a twofer, and we showed some of that in our work. You get some weight effects as well as hypertriglyceridemia, including effects. A lot of people who suffer metabolic dysfunction and severe mental illness tend to be young, early on, and so LDL tends not to be. Also, they don't score on the family and risk criteria if they're under 40, which again is a double whammy because they don't get prescribed statins even if they are indicated. And so Benjamin Perry, who's a colleague out of Cambridge, and now he's on to, I'll name it on 7 p.m. So he has developed a very nice calculator called Psychiatric, which I would like to highlight for our attendees. It's an app-based tool that you can put in your patient's parameters, and it will tell you what their risk for developing weight gain, diabetes, and metabolic syndrome is in 1 to 5 years. And using that can be an interactive tool that you can sit down with your patient and think about what needs to be done preventatively or in an intervention space, and then refer out as needed and start medications as needed. So yeah, actually we should have spoken about that. Thank you, Mark.
Yeah, it's a great topic. Maybe it could be another whole session. But I guess I'll comment briefly is that with the ketogenic metabolic therapy pilot, we did analyze the ASCVD risk score. There was no significant difference or change while we were looking at, because sometimes this ketogenic